sir has given me the responsibility of talking about Venetoclax in CLL. So over the next 15 minutes, I'll be quickly winding up what is the current day role of Venetoclax in CLL and how do we look at the future. So to introduce, I would not like to repeat most of the things which have already been excellently covered by Dr. Akansha in the previous slides, but just to say that in the last 5 years, starting from accelerated approval to approval for even first-line therapy by May 2019. So the drug in 4 years has spanned to first-line therapy in CLL. And as Dr. Akansha said, it's a second-generation BCL2 inhibitor, the first generation being Navitoclax, which used to inhibit both BCL-XL as well as BCL2, whereas the Venetoclax only inhibits BCL2. So the unnecessary adverse events are taken care of, particularly the thrombocytopenia part of it. Now, among all the important pharmacokinetic features, the metabolism in liver by CYP3A4 is an important aspect for Venetoclax because that would dictate dose modifications with certain other co-medications that we routinely prescribe. And the antifungal prophylaxis by either posaconazole or voriconazole would warrant a decrease in dose of Venetoclax by around 30 to 50% of the dosages. Now, in Indian scenario, this particular feature can be used actually to cut down on the prices, though we need to study it in a long term, in a prospective manner to see whether that would really help the patients by cutting down the dose by using concomitant azoles. Now, special situations, as has already, we need to decrease it by 50% reduction, whereas as you see for the rest, there is no renal modification. It's contraindicated in pregnancy and breastfeeding. In geriatric patients, please use the cumulative illness score, the CIRS, for dictating the dose. And it does not require a change in dosages for the obese patients. Now, the dosing has already been described, but I would like to add up 1 or 2 points. One size doesn't fit all. So, you need to actually go to what type of regimen are we prescribing. So, if it is a single agent Venetoclax, the dosing schedule would be different. When we are going to combine it with other drugs, the dosing schedule would be different. As you would see on the right side panel, in patients when we give it Venetoclax with obinutuzumab, we don't start the treatment upfront on day 1, whereas we shift it to day 22. Whereas when we combine it with rituximab, we start it from day 1 onwards. Whereas when we give it with ibrutinib, we give it from day 28 onwards. So it changes depending upon what combination are we using. Now coming to the timeline on CLL therapy and where did the Venetoclax come in and fit into this timeline. So if you look in 2015, the observation for the patients who didn't have an active disease as per the IWG CLL guidelines, followed by that, based on the age and comorbidity, people used to prescribe chemoimmunotherapy by FCR more than bendamustine rituximab and followed by a BTK inhibitor or PI3K inhibitor in combination with CD20 inhibitors. But if you compare the same on today's date, though the observation remains static, but the FCR and the BR have actually shrunken into overlapping thing. Many people now even prefer BR over FCR, particularly because of the less side effect profile and the less toxicity. And in fact, I kept the FCR circle slightly ahead for the sake of the teachers who have been practicing FCR for a very long time. But the point to note is both the BTK inhibitors and BCL2 inhibitors have come up in the front line. If you compare it with the small cartoon on the right side upper corner, so they are no more the therapies for a sequential therapy after the chemoimmunotherapy, whereas you can start prescribing both ibrutinib as well as Venetoclax in the upfront scenario in combination with any of the CD20 inhibitors. Now, what has changed as far as the perspective of treating CLL is concerned? So now most of the physicians desire that we should not have too much of a myelosuppression or infections. They don't want a long-term marrow damage or they want to avoid a secondary malignancy risk as generally seen with the chemoimmunotherapy. Most of us prefer targeted therapy over chemoimmunotherapy because of the oral treatment, less hospital admissions, and particularly in the West owing to the insurance problems for in-hospital versus OPD patients. Also, most of these drugs, that is the ibrutinib and as well as the Venetoclax, they give you prolonged CR or increased progression-free survival when compared to chemoimmunotherapy or chlorambucil. And nowadays, we talk of achieving MRD in most of the diseases and as well in CLL as well. So, no more a complete remission or partial remission is an endpoint, and most of us want to achieve a MRD to achieve in the future a longer treatment-free remission. So achieving MRD is possible with Venetoclax, which is not possible with ibrutinib or with chemoimmunotherapy. And most of us look at definitive duration of therapy when compared to a continuous therapy as seen with oral ibrutinib. So with these things in mind, the things have changed. These are the various places where the targeted therapy acts. If you see the Venetoclax, it acts at the BCL2, the ibrutinib at BTK, and ilotinib at PI3. What I want to basically bring out is they are all independent actions. So a combination, a permutation combination of these drugs might act rather than a monotherapy per se to lead to an overall greater benefit. But keeping in view the toxicity profile, which might also add up from one drug to another. Now, if we compare the three targeted therapies, that is ibrutinib, acalabrutinib, and the Venetoclax on today's date, the pros and cons. The ibrutinib has the longest follow-up studies which are available. So we know more about ibrutinib when compared to the other two agents. But the cons are basically we have got indefinite duration of therapy. It leads to low complete remissions and low MRD, and it has side effects of atrial fibrillation and bleeding. Whereas acalabrutinib, the advantage is it has a reduced off-target effects as seen in ibrutinib, but the false side of it is we don't have a longer follow-up. It has to be given for indefinite duration, and as in ibrutinib, it does not lead to a higher proportion of CR or MRD. Lastly, coming to Venetoclax in combination with Gazyva. So the advantage is it can be given only for limited duration. It leads to very high CR rates and MRD rates, but the false side of it is we do not have long-term studies. The tumor lysis syndrome, as was mentioned by the previous speaker, is a major problem, and IV administration of obinutuzumab would require still some amount of daycare / in-hospital observation. Now, if you look at this screen, this I pulled it out of a Blood article, How I Treat article, which was published around a month back. Very surprisingly, I find that in either TP53 mutated or intact patients, you see that ibrutinib with or without CD20 inhibitors being seen as the first-line therapy in all groups of patients. Whereas the chemoimmunotherapy has been restricted only to those patients who are younger, fit, who have a mutated IGHV and an intact TP53. So this shows how the world has been changing as far as treating CLL is concerned, though I might not fully agree with the author's choice and the preference, but I just brought this out to say how the guidelines and the things are changing over a period of time. Now you have to understand that improved PFS but not overall survival is seen with most of the targeted therapies, and all these studies have taken PFS as a surrogate for overall survival. But there are no studies to clearly prove that we can use PFS as a surrogate for overall survival. So when you read all these articles or these guidelines, you have to bear this in your mind. Now, when we look at the previously treated, that was for the first line therapy, and now this is for the relapse refractory setting. Again, you could see that Venetoclax features in almost all the groups wherever the patient had been exposed previously to BTK inhibitors or not to BTK inhibitors, or to chemotherapy or not to chemoimmunotherapy. So, this is how the previously treated patients are being managed in the West on today's date. Now, if in India, if I have to say what I should be taking into consideration for choosing first-line therapy, the essential considerations that I should have is what is the age of the patient, what are the comorbidities, what is the TP53 status, and what is the IGHV mutation status, which are absolutely mandatory to record before starting any therapy. The additional considerations of cardiac history and status, because ibrutinib is associated with atrial fibrillations and cardiac comorbidity. Concomitant medications, because both ibrutinib and Venetoclax lead to CYP3A4 induced metabolism. Renal functions for ibrutinib and for chemoimmunotherapy. The bulk of CLL for Venetoclax, because it leads to tumor lysis syndrome when the bulk is high. And most importantly, the financial status and the logistic access to the different forms of therapy. Also, other than these patient-directed factors, the doctor or the physician who is treating need to have few goals in his mind. Are we looking for a fixed duration therapy or a continue looking at achieving deep remissions or prolonged treatment-free remissions? How much is the exposure time I am looking for? What is the potential for toxicities and how can I reduce it? And what about the long-term compliance of the patients? Because if I start prescribing ibrutinib for a 40-year-old guy for the rest of his life? Will he be able to take it or not? So these things needs to be taken into consideration before we choose the first line therapy. So the major advantages of Venetoclax versus any other therapy is a fixed duration of the treatment and the advantages of having higher rates of MRD or CR when compared to any other drug on today's date. So if we look at, these are the various studies which have been published on Venetoclax till date. If you look at the top few, the top 4, these are the ones which were actually when the Venetoclax was used as a continuous therapy and mostly in relapse refractory setting. This led to the approvals of it, but you can actually discount most of the studies because they are all phase 1 or phase 2 studies. But if you look at the phase 3 studies, so the MURANO, CLL4 and the MD Anderson studies are the one major landmark studies which I am going to describe in detail. Now the first landmark study, that is CLL14 study in untreated CLL. So in patients who have never received any form of therapy but who had multiple comorbidities as seen by CRIS score of more than 6 and a creatinine clearance of less than 70, the patients were given either Venetoclax with obinutuzumab or chlorambucil with obinutuzumab for a total of 28-day cycle, for Venetoclax 12 cycles and obinutuzumab for 6 cycles. The primary endpoint was PFS as assessed by the investigator, and there were multiple other secondary endpoints. So if you look at the primary endpoint, there was a definitive difference between Venetoclax versus chlorambucil when combined with a common CD20 inhibitor. But the point which needs to be noted is the difference started occurring only after the first 1 year. So any patient who is being started on Venetoclax, don't expect differences when compared to the previous chemoimmunotherapies upfront. You would see them in long term, but not in the immediate near future. By comparing it with the IGHV mutation status and TP53, definitely Venetoclax had a better survival both in TP53 mutations as well as in IGHV unmutated patients. And if you look at the responses, so the overall survival was not different as I was previously mentioning. Only there was a PFS difference and a difference in the CR versus PR rates in both the groups. And if you look at the MRD negativity, so the UMRD that we commonly called as is undetectable MRD, wherein we look for 1 cell out of 10,000. So we say that it is 10 to the power of -4 sensitivity, either in blood or in bone marrow. So if you look at that, so that was statistically significant in Venetoclax versus chlorambucil. And when you looked at 10 to the power of -6, it was also seen in much higher patients when compared to 42 versus 7. Now coming to the safety, if you look at the neutropenia and the total adverse event, grade 5 adverse events, they were higher when compared to the chlorambucil, but only statistically significant difference was the metabolism of the nutrition disorders, and there was no difference statistically in any other grade 3, 4 or 5 adverse events. So this was as far as the Venetoclax in the upfront patients where we are giving it as a first line of therapy. The summary would be to say that these are those patients who have multiple comorbidities, have very high median age, and still it was found to be beneficial. Now, if you look at the Venetoclax in the previously treated CLL patients, that is the MURANO study. So, in this, the Venetoclax with rituximab was compared with bendamustine with rituximab, and you could see a wide apart graphs of VR versus BR, and the Venetoclax rituximab had higher PFS as well as overall survival, but the OS was not statistically significant. If you look at the safety profile, the neutropenia was much higher in patients with Venetoclax versus bendamustine, but the febrile neutropenias were higher in BR when compared to Venetoclax. So most of these neutropenias which were seen with Venetoclax did not actually require in-hospital therapy or observations for febrile neutropenia, and they were actually could be managed just with GCSF supplementation, as was told by the previous speaker. Now, if I have to compare, on today's date, the favorite girl in the market as far as CLL therapy is concerned is ibrutinib. And if I want to compare my product, which I'm talking today of Venetoclax versus the proven product ibrutinib, so it's like comparing Katrina Kaif with Anushka Sharma. Now, sorry for these online meetings, I can't see the saliva drooling out of the mouths of the audiences, but still, if I have to compare these two heroines, So the BCR inhibitor ibrutinib has a better effect on the nodal disease, whereas venetoclax has a better effect on the blood or the marrow disease. The lymphocytosis would be seen secondary to ibrutinib as a side effect, and previously there used to be a terminology known as PR with lymphocytosis whenever the ibrutinib was launched initially. And if you look in relapse refractory setting, the patients who achieved CR was very high with venetoclax when compared to ibrutinib. And the adverse event profile, we have already discussed the comparison between the two. Now, generally, we are taught that we should never compare two different studies because the study populated. But just for the sake of it, if I have to see, a median age between both of them was common. And if you look at these red lines, the 3-year progression-free survival was 82% in both the groups. But the point to be noted is that these patients in CLL14 had a much poorer profile when compared to Resonate study. So this is the comparison of venetoclax versus ibrutinib, which I have already covered in the previous slides. Now, why should we compare? Can we not combine both? So it's like Yash Chopra film wherein you bring both the heroines together. And in this film, Nitin Jain from MD Anderson was the Yash Chopra, and he brought in a study wherein he combined ibrutinib with venetoclax and published last year in NEJM. And you would see that if after 3 cycles of ibrutinib, the number of patients who are achieving complete remission, as seen with dark blue, was very minuscule. Whereas after 18 cycles of venetoclax with ibrutinib, the number of patients who had achieved CR or who have achieved the MRD is much higher. So there is a role, might be a role of combining ibrutinib with venetoclax, but the audience have to understand that the toxicity profile also gets added, and so the patients might actually have a more toxic profile and more things to look at. Now I'll quickly cover 3 special issues with venetoclax. TLS has already been covered by Dr. Akansha. So I'll just talk about the mitigation. When we are talking of combining with Gazyva, so never start the venetoclax up front. Give Gazyva in the beginning because it decreases the lymphocytosis, so it decreases the blood and the bone marrow load, so the chances of TLS decreases. Secondly, don't do the CT scan, staging CT scan upfront. Do it at day 22 or at the start of the cycle 2 because you can exactly know how much nodal disease is remnant in the particular patient. So you can assess the TLS risk better when compared to doing a staging CT scan upfront. And you can admit the patient not for the cycle 1 but might be for the cycle 2 during the ramp-up phase for mitigating the TLS. Now, the second issue is venetoclax-induced neutropenia. This was also partly covered by the previous speaker. So what I would just say is give GCSF intermittently to make sure that you do not decrease the dose in the first 3 months of the therapy. Because the rationale for not decreasing the dose of venetoclax is CLL or any indolent lymphoma has a high burden of disease in the bone marrow. So by maintaining the venetoclax dose at 400 mg, there is a chance of clearing the marrow and a better recovery of count and a better progression-free survival. But if the patient has a recurrent neutropenia for more than 3 to 4 months, then you can look at drug-drug interactions or look at highest tolerated dose of venetoclax along with GCSF. Now, lastly, the resistance to targeted therapy. Now, ibrutinib can have resistance in these 3 particular fashions, and you can use BTK inhibitors in all 3. Idelalisib can have in these 3 fashions, MYC amplification, PI3 amplification, and unknown patterns. So you can again use the venetoclax both in type 1 and type 2 resistance. But if I look at venetoclax in relapse on ibrutinib, which is the commonest thing which is happening on day-to-day practice in the West currently, so preferably add a CD20 inhibitor and don't give single-agent venetoclax. Now, obinutuzumab has not been approved for relapse refractory setting, so rituximab remains the therapy. The median PFS for relapse refractory deletion 17p CLL with venetoclax was 24 months. So if you add rituximab, it can be much higher. Please continue ibrutinib along with venetoclax, even if you are looking at ibrutinib resistance, because whenever you withdraw a BTK inhibitor in patients who are on long-term therapy, there is a chance of CLL disease flare. So the BTK discontinuation should only be done after venetoclax has been given for 1 to 2 months or after the ramp-up. The TLS risk assessment should be done by staging CT scan and mitigation strategies as told previously, and prolong the venetoclax beyond the fixed duration of 24 cycles if the patient has got TP53 mutation or has not achieved MRD positivity after 24 courses of venetoclax. Now, venetoclax is not a God's own product. It can also have resistance, and in case of resistance, there is an option of using idelalisib or CDK9 inhibitors or ibrutinib if not used previously. So this is your condition after listening to Venetoclax for the last two symposia. So if I want to say my interpretation in one slide of how I would take it, I will place Venetoclax with confidence in CLL whenever the patient has a TP53 mutation or an unmutated IGHV, or if the patient has multiple comorbidities, and particularly if I am keen on giving fixed duration therapy and not lifelong therapy. Patients relapsed on BTK inhibitors, this definitely remains to be the drug of choice. Venetoclax in India, still chemoimmunotherapy remains the gold standard at many places because of the financial reasons, fixed duration, and experience of our dear oldies. Now, changing scenario to new gold standard ibrutinib, particularly with the advent of generic ibrutinib now, which is available in the market. So, ibrutinib can be given if you are taking the finances into account. Venetoclax has to compete the prices with the generic ibrutinib in the market for it to see the light of the day. The cost also gets compounded by additional costs of obinutuzumab, hospitalizations, and the serious adverse events. So we need to bear that in mind. So Venetoclax certainly is the future in both upfront as well as relapsed refractory setting if economically viable. And nowadays, no presentation is complete without COVID, and that too particularly when a talk is being organized by Mumbai Hemato-oncology Group, the epicenter of COVID in India. So I will choose ibrutinib over any other agent because of the least chances of toxicity and the neutropenia when compared to any other drug for CLL on today's date. Not only for that, but we have a publication this week, around 2 days back, wherein there is a study on around 10 patients of BTK inhibitor ibrutinib, which may protect against pulmonary injury in COVID-19, and they have presented data of 8 patients out of this 10, and they say that BTK inhibitors actually protected the patients in severe COVID patients. So ibrutinib might stand over Venetoclax if the COVID has to continue for the next few months to go. So I thank everyone for a patient hearing, and these are my disclosures. Thank you.